Hello and welcome back to my channel. My name is Ramela and today we will be discussing types of valvular diseases and we will be concentrating specifically on aortic stenosis. Like I said in my previous video, I will be teaching you from First Aid MCCQE book, and along with that I will also be using other resources to make everything crystal clear to you. Let's begin. What is aortic stenosis? Aortic stenosis is basically when this valve, which is between the left ventricle and the aorta, becomes narrow and enough blood cannot be moved from the left ventricle into the rest of the body via aorta. What are the causes of the aortic valve being stenosed? There are three main causes that we will be discussing today. The first one being senile calcification. Senile basically means old, and calcification basically means buildup of calcium onto something. Senile calcification refers to the fact that with age, what's going to happen is that your valves are going to become sluggish, due to which the calcium is going to deposit on them, and that is going to make your valves narrower. Now, it's not important that it will happen in everyone, but it does happen in some elderly at the ages of 50s and 60s. So this was cause number one. Cause number two is a unicuspid valve. Unicuspid valve is very rare and it is a congenital anomaly. It doesn't happen in everyone. It probably happens in very few unfortunate people in their childhood and adolescence, and that is cause number two. Cause number three is rheumatic heart disease, and the pathophysiology behind the rheumatic heart disease affecting the aortic valves is that when Streptococcus pyogenes, which is a kind of a bacteria that causes sore throat, and if the sore throat is left untreated, that will lead to rheumatic fever, and the rheumatic fever in turn will lead to rheumatic heart disease, which basically means that your body will form antibodies against the Streptococcus pyogenes, and those are going to be called anti-Streptococcus antibodies. The anti-Streptococcus antibodies can cross-react with your tissue. Some of the common tissues affected are the brain, the heart, and your joints. And why does that happen? Because these tissues have antigenic similarity with the streptococcal component, and this is called molecular mimicry. What this does is that your body's own immune system will start attacking your own tissues, and in your heart the most commonly affected areas are your aortic valve and your mitral valve. So this is the pathogenesis behind how rheumatic heart disease can predispose to aortic stenosis. So basically we have three kinds of etiologies. One is the elderly, one is the unicuspid valve, and one is rheumatic heart. Moving on to history and presentation. How will the patient present to you? The patient for the longest time will be asymptomatic until the stenosis becomes so severe that the patient comes with symptoms. If the patient comes with symptoms, the symptoms are going to be lightheadedness with exertion, syncope with exertion, maybe chest pain as well. Lightheadedness and syncope with exertion, why would it happen? Because the valve will be so stenosed that enough blood will not be able to pass through the valve into the rest of the body, especially during exertion when the rest of your body needs a lot of blood, and that is when you will become lightheaded and you will have syncopal attacks. So the patient would usually present with lightheadedness and syncope on exertion. So keep that in mind because that will come up in your exam questions. So what are some of the diagnostic findings that you will find with people that have aortic stenosis? So when you examine the patient, you will find pulsus parvus et tardus. Parvus basically means weak and tardus basically means slow. So your carotid pulse will be weak and delayed. You will also have single or paradoxical split S2. Now, what does that mean? Single S2 basically means that when your aortic valve is so stenosed, the closing of the aortic valve does not make any sound. So your S2 is composed of A2 and P2. So if the A2 component is gone, you will have only the P2 component, and this is called single S2. What is paradoxical split S2? Let's talk about how a normal S2 looks like. Normal S2 has two components, which is A2 and P2. A2 being closure of the aortic valve and P2 being closure of the pulmonary valve. With expiration, these two components are very close together. and they don't split or go away from each other. But with inspiration, there is a little bit of a physiological split between the A2 component and the P2 component of the S2. This is how normally it works, but when it is a paradoxical splitting, reversal happens. So the reversal will happen in two things. One reversal will happen in the P2 and the A2 component, where they will reverse their places, which means the P2 will happen first and the A2 will happen second. Why would it happen second? Because it will be delayed. Another thing that is going to be reversed is that with expiration, there is going to be a splitting, and with inspiration, they are going to come closer together. So that is called paradoxical splitting, and this is because of the delayed closure of the aortic valve, and it happens with aortic stenosis, left bundle branch block, and hypertrophic cardiomyopathy. If you remember from the previous video where I showed you a mnemonic called Mr. S, which means mitral regurgitation and aortic stenosis both have systolic murmurs, here is the time we will discuss that murmur. Aortic stenosis is going to have a systolic crescendo decrescendo murmur at the right intercostal space radiating to the carotid. Let's explain that a little bit. The aortic murmur or aortic heart sound can best be heard at the second intercostal space. So this is the first intercostal space and this is the second intercostal space, and if you put your stethoscope here, you would be able to hear the aortic stenosis sound the best, and this will radiate to your carotid, so it means that it will radiate towards your neck. Another thing is that this will be a systolic murmur, so it will happen between S1 and S2. And the third thing is that it is a crescendo decrescendo murmur, so it will go up in intensity and then slow down in intensity. So that explains the murmur of aortic stenosis. Like I told you earlier, if aortic stenosis becomes very severe, there's going to be a soft and single S2, which basically means the aortic valve will make no sound, and the sound that you hear will be for P2, that is the closure of pulmonary valve. The investigation of choice for aortic stenosis is echocardiograph, and you can also do ECGs, and in ECGs you will find left ventricular hypertrophy, left atrial hypertrophy, maybe signs of left bundle branch block, and atrial fibrillation signs and symptoms as well. Now, how will you assess the severity of aortic stenosis? So to assess the severity of aortic stenosis, you need to look at the pressure difference between the left ventricle and the aorta. Normally these pressures match and there is zero gap, but if there is a gap between these two, that is pathological. Let me show you a graph over here. So as you can see, this is the left ventricular pressure graph and this is the aorta graph, and there is a gap between them, and that gap is not normal. If you trace the gap to here and here, you will find that this gap is approximately 20 mmHg, which is not normal. It is supposed to be 0. Now, to assess the severity, we need to look at this graph. If the graph between them is 0 to 30 mmHg, then it is mild stenosis. If the gap is 30 to 70, it is moderate stenosis. And if it exceeds 70, then it is severe stenosis. Other than that, to assess the severity of aortic stenosis, we can also look at the diameter of the aortic valve. So normally the diameter of the aortic valve is 3 to 4 centimeters. If it becomes 1.5 to 3 centimeters, it is mild stenosis. If it becomes even smaller and becomes 1 to 1.5, it is called moderate. If it is less than 1.5, it is called severe. And if it is less than 0.5, it is called very severe stenosis, and we need to operate right away. Now let's talk about how we can treat patients that have aortic valve stenosis. The first and foremost thing you need to do is aortic valve replacement. There is no medical treatment for aortic stenosis, and we need to go for aortic valve replacement. This can be done surgically or with transcatheter method. One thing I want you to remember is that we need to avoid at all costs nitrates, ACE inhibitors, and arterial dilators. And the reason behind this is that it will dilate the aorta and the arterial system, and that will cause an increase in the afterload, and that will further decrease the blood pressure, which will cause syncopal attacks and blacking out and all of that. And we do not want that, because that is already happening in patients with aortic stenosis. So avoid at all costs nitrates, ACE inhibitors, and arterial dilators. One more thing I want to discuss is subclavian steal syndrome, which basically looks a lot like aortic stenosis but is different in two regards. The one being murmur will be heard a little further above, and another difference that you can find is that the blood pressure in both arms is going to be different. So the blood pressure in the right arm and the left arm is going to be different. Subclavian steal syndrome occurs due to occlusion of subclavian artery proximal to the vertebral artery. I will do another video on this and will explain in details, but you just need to remember that this is how you differentiate between aortic stenosis and subclavian steal syndrome. Look at the BP in both arms and look at the murmur. If the murmur is a little higher and the BP between both arms is different, that is when you should know that you have subclavian steal syndrome at hand. One more thing I want you to remember with the murmur of aortic stenosis is that it will increase with hand grip, squatting, leaning forward, and leg raise, and it will decrease with Valsalva maneuver and standing up. Now that we have a good understanding of aortic stenosis, I want to solve a question with you guys. I have taken this question from UWorld, and let's talk about it. A 60-year-old man, so senile man, comes to the office due to several episodes of lightheadedness. So several episodes of lightheadedness over the last 3 months. He experiences these episodes while trying to walk quickly or climb stairs. So this means lightheadedness with exertion. He almost passed out, syncopal attack, during the last episode. The patient describes his lifestyle as active, but recently he feels more tired than usual during his daily activity. I told you in the presentation that chest pain is a little rare or palpitation. Medical history is significant for diverticulosis, for which he takes fiber supplements. They will throw things like that to divert your attention, but ignore these things. The patient is on no other medications. Temperature is 37.1, so not that high. Blood pressure is 108/92. Pulse is 88 per minute, and regular respirations are 14 per minute. On examination, he has 3/6 systolic murmur that is best heard over the right upper sternal border. At the right upper sternal border, we know that the murmur of aortic stenosis can be best heard. Carotid pulses are slow rising and delayed. If you remember, pulsus parvus et tardus, they're talking about that. And the lung fields are clear to auscultation. There is no peripheral edema. Which of the following additional findings is most likely to be seen on physical examination? Apical mid-diastolic murmur, no. In aortic stenosis, you don't find a diastolic murmur. Audible S3, no, because audible S3 is heard with aortic regurgitation, mitral regurgitation, and heart failure. Early peaking systolic murmur, no. So early peaking systolic murmur is heard in those patients that have mild or moderate aortic stenosis and not severe. But since this patient is experiencing syncopal attacks and he has become symptomatic, that means that he has severe aortic stenosis, so we will cross that out as well. Loud S1 will not be heard because loud S1 is usually heard in patients with mitral stenosis. So in my head, soft and single S2 will make most sense. So if you remember, the two components of S2 were A2 and P2. When there is aortic stenosis, the A2 is already so stenosed that you cannot hear it closing, and the only thing you will hear is the P2 closing. So that's why soft and single S2 makes most sense. So these are the kinds of questions you will be getting in your exams, and we will be solving these kinds of questions at the end of every video. If you liked this video, I want you to please subscribe to this video and share it with your friends that are going to take USMLE exam or MCCQE exam, and let's become study partners. I will see you in the next video. Till then, take care of yourself. Bye.